Next one is the advantage of thoracoscopic Cdh repair. That's avoiding adhesive Sbo offset the risk of Cdh recurrence. Presented by Dr. BHATIA.
Thank you for this opportunity to present our series on congenital diaphragmatic hernia and small bowel obstruction. We have no disclosures. Minimally invasive surgery for repair of diaphragmatic hernia has been around for 15 years, but its merits are still controversial. Clearly, it allows for smaller incisions and minimal handling of the bowel contents. One concern has been some reports of increased recurrence rates, especially in patch repairs. But less talked about is the risk of adhesive bowel obstruction. We know that adhesive bowel obstruction is a concern after neonatal laparotomy, and even more so after congenital diaphragmatic hernia repair, especially with patch repairs. This is a lifelong risk, and there's a risk of bowel loss. So our aim was to compare the risk of recurrence and adhesive small bowel obstruction between thoracoscopic MIS repairs and laparotomy, or open repairs, of Bowel-type congenital diaphragmatic hernias. This was a single institution retrospective chart review for all our CDHs from 2000 to 2013, allowing for at least 1 year of follow-up. We chose the group by their first method of repair. Subsequent repairs were not included. And we excluded repairs other than by thoracoscopic or laparotomy, which were the majority of the repairs. We looked at recurrence, adhesive small bowel obstructions, as well as mortality. And we stratified the data by patch and primary repair, with those that had a patch reinforcement with an absorbable mesh included in the primary repair category. We use a Mantel-Hensel chi-square to have a stratified type comparison, and we also looked at survival curves. So there were 195 CDH repairs performed. It was attempted in 115 to do it thoracoscopically, and we were successful in 68%. Those that were not successful and were converted were, because of the morbidity of the laparotomy, were included in the open repair. Those others were included, those that were done laparoscopically or by thoracotomy, and were a smaller number. So if we looked at the patient characteristics, clearly the open group was a more complicated group. They more likely had a prenatal diagnosis. They were more likely to be on ECMO. They were most likely to have large defects with liver in the chest, as well as needing a patch repair. Looking at our results, the recurrence rates did not, even with stratified by patch and primary repairs, did not reach significant differences, with the totals being similar, but a trend towards higher while stratified, though not significantly different. However, there was a very significant difference in our adhesive small bowel obstruction. I apologize for the reformatting that had happened with this, even when stratified by primary and patch repair, there were no adhesive small bowel obstructions in the thoracoscopic group, while overall 14% in the open group. If we looked at a Kaplan-Meier curve of recurrence rates, recurrences tended to happen early within the first couple years, although there are later recurrences. And there seems to be some trends in higher in patch as well as in MIS patch repairs. However, there's significant overlap in these curves with, if you add the 95% confidence intervals, you can see there's the only two that are significantly different is the thoracoscopic patch from an open primary repair. All other curves overlap. If you look at the adhesive small bowel obstruction rate, and again, these only include the first obstruction, not subsequent obstructions. Again, they more likely occurred earlier on, but can happen later on as well. and there was just a 0% in the thoracoscopic group. So, using a little creative license and in a hypothetical world where we could have done all the open ones theoretically, thoracoscopically, we might see an increase in some recurrence rates using the percentages that we had in our study, but we would avoid small bowel obstructions with a saving of first time having to go in for a repeat operation for one of those two things. Conversely, if all the thoracoscopic were just done open, we might have a few less recurrences, but we'd have more adhesive small bowel obstructions, resulting in a slight increase in the number of intervention needed. Again, these are different groups, and certainly we couldn't completely accomplish it at this point on all our opens, but it gives you an idea of how these two risks balance each other. So in summary, small bowel obstruction is strongly associated with open repairs. We really didn't have any, and I still, as far as I know, have none in our thoracoscopic repairs. And these were significant even with adjustment for patch repairs, and there were adhesive small bowel obstructions in primary open repairs. Our recurrence rates, although they trended to be different, were not significantly different between the MIS and open repairs. But there were limitations clearly to the study. The open repairs had more complex patients, and not all of them can be accomplished at this point thoracoscopically. Indeed, there's other confounders that may be in there, including LADS procedures and fundoplications, and there is that temptation to do a LAD procedure while you're there on an open laparotomy, which may make things more prone for adhesive bowel obstruction. MIS repairs for large defects remain challenging, and I did not look at second recurrences. We know that kids that recur sometimes recur a second or third time. But again, we have recurrent adhesive obstructions that kids that have one obstruction often have a second or third. So in conclusion, I want to bring about the point that we need to think about, in children particularly, who have lifetime risks, balancing these different risks. A small bowel obstruction is a lifetime risk, as well as a recurrence of a diaphragmatic hernia being a lifetime risk. And both of these risks should be considered when weighing the different risks. However, the potential to improve our adhesive bowel obstruction rates after open laparotomy remain limited. As we continue to improve on our technique for thoracoscopic hernia repair, we may continue to improve our recurrence rates. And as we do that, we may tip the balance in favor of MIS repair. Thank you for your attention.
There's time for one question only, please.
Great series. Thank you for sharing. My question to you, though, what percentage of these kids actually have bowel obstruction as a result from the recurrence? And if so, how do you tease out between the adhesive versus the incarceration as a cause of the recurrence?
I'm sorry, repeat the very first part of the question. How many had?
What percentage of these kids actually have obstruction as a result from the herniation or recurrence? And if so, how do you tease out between the adhesive versus the recurrence?
Clearly, obstructive-like symptoms occur with recurrence, and it's important to know if this is adhesive or recurrence. This came up very recently. One of the picture I had shown of a recurrence with a thoracoscopic was a partner of mine who was convinced it was adhesive, and I said, this is going to be, and I went in through the chest to, he was on vacation, so he didn't get a choice, and sure enough, it was a nice recurrence that I was able to take care of, and the kid was great. You have to use your judgment of whether it's adhesive, or certainly on the opens it can be either, and we certainly have obstructive, but typically you can use your radiographic imaging to tease out whether your obstructive type symptoms are from a recurrence or adhesive.